Hello, everybody. I am Dr. Amr Khairi, head of the orthopedic department at Shams University. Tomorrow, Egypt will dazzle the world with an unrivaled event by the Pharaoh's Golden Parade, on which 22 royal mummies will reach their final home. And today, I hope, as usual, Ain Shams orthopedic department will dazzle all orthopedic surgeons by an unrivaled webinar discussing a very crucial subject, which is important for all of us: fracture-related infection. It will be in two parts. Today will be the first part, and the next Friday will be the second part. It is our 35th webinar and the 12th in season 2. In this era of pandemic and lockdown and social distancing, still Ain Shams doing her educational mission to continue our online education and to exchange experience among surgeons on the national and international level. Today, as I mentioned, we'll have fracture-related infection, a very crucial and important subject. Our moderator will be Dr. Mustafa Baraka, one of our distinguished surgeons. We have a very, very strong panel today, starting by Professor Dr. Zahir Hassan, the head of the trauma team, Professor Ibrahim Ganzouri, who has many publications in trauma and in arthroplasty, and Dr. Mahmoud Mahran. And I have two very distinguished guests, Professor Willem Mitsmakers, the trauma consultant of Belgium, of Leuven, from Leuven, Belgium. We are happy to have you with us, Willem. And Professor Andrew Trampouz, infection disease consultant, Charité University Hospital from Berlin, Germany. Very respectable figures. We have them today to exchange our experience with them. We are very happy and very glad to have them in our team today. And today we have two speakers, Professor Gebeli, Mohammed Gebeli, and Dr. Ahmed Mansour will have very interesting cases trying to hold the whole subject of infection. Dr. Baraka, I will turn the mic to you. I will never forget Elixir, our partner. Thank you, Elixir, for your help and support. And finally, Dr. Baraka, I wish you all the best of luck and I wish you a fruitful night. And the third mic to our moderator, Professor Mustafa Baraka. Please, Baraka, start.
Thank you, Professor Amr, for your introduction. Good evening, everyone. I would like to welcome all our distinguished panel speakers and attendees to our meeting today. Infection remains the most devastating complication for all orthopedic trauma surgeons. In this webinar, we're aiming to highlight the challenges in diagnosis and the common pitfalls in management according to the most recent evidence and recommendations. Today's webinar will run in 2 sessions. Each will start with the case discussion, followed by a summary of the evidence. We will have a few minutes at the end of each session to address questions. So if you have any questions, please type them below in the chat box. Dr. Gebeli, would you please share your screen to start our first session?
May I add a point? This I'd like to welcome one of our friend from Jordan. He is the chairperson of the AO Trauma Jordanian chapter, and he's Dr. Hashim Quda from Amman, Jordan. He's joining us, and he's one of the attendee to that meeting. So welcome, Dr. Hashim. Okay, go ahead.
Okay, Dr. Gebeli, would you please start our first session?
So 1 minute, please, Baraka. Okay. Hello, everybody. I am Mohammed Gebeli, Assistant Professor of Orthopedic Surgery at Shams University. I'd like to thank Professor Amr for inviting me to share this case with you in this webinar. And I'd also like to welcome my colleagues, Baraka, and my professors, Professor Al-Zahir and Professor Ibrahim Ganzouri and Professor Mahran. Also, I'd like to welcome the guests, Professor Metzmaker and Professor Willem. Session one, we will have introduce the consensus about fracture-related infection and how to define the FRI and what are the diagnostic criteria. Explain implant-related infection and why it differs than prosthetic-related infection or other bone infection. Discuss appropriate timing of surgical intervention and how to decide when to retain the implant or to remove it and choose another implant. This is a 44-year-old male. He is a smoker who was subjected to a road traffic accident, which resulted in fracture both bone distal leg, which was open grade 3A as in Gastello classification. This is a plain X-ray comminuted distal tibial fracture with open fracture. The patient was taken directly to the OR within the 24-hour. Debridement and irrigation was done. And we see that there was no periosteal stripping and we can primarily close the wound. So we decided to do directly internal fixation with the MIPO technique. And the patient continued IV antibiotic for 72 hours and was discharged on amoxiclav for 2 weeks after surgery.
Okay, Dr. Gebeli, we'll have a small pause on this slide. Dr. Ibrahim, do we have a safe interval to apply internal fixation in these injuries? Dr. Ibrahim, do you hear me?
Sorry, I was muted. Actually, I don't think we have a very strict timing or a frame. However, it's accepted to do internal fixation within a 24-hour period, putting in mind that we have a wound that can be closed primarily with no tension on the skin and no gross contamination to the wound. So that patient was debrided within 24 hours. However, I don't think that skin condition is the optimum one for internal fixation.
Okay, Dr. Willem, do you have a preference for the type of fixation in these injuries? Or do we have an established consensus regarding this respect?
I agree with Dr. Ibrahim. I think the soft tissues are not ideal at this time for an internal fixation. So as the AO also teaches, is fixate at this moment and then plan, do a scan and then plan the surgery in a later stage.
Okay, Dr. Andre, is there a role for tissue cultures during the time of the primary debridement of open fractures? Would you recommend to have a sampling for tissue cultures at this stage?
No, at the primary implantation, it's probably a mixed infection or at least colonization. So there is not necessarily a microbiological diagnosis.
Okay, thank you, Dr. Willem. We have a myth in our practice that every patient who had internal fixation has to be discharged on a fixed 2 weeks oral antibiotics, like in this case. And we need to sort this issue out. Is there a role for prescribing oral antibiotics for 2 weeks for every patient, every trauma patient who had internal fixation?
No, not at all. So the Boxma trial in 1998 showed for closed fractures that a single dose is enough. And for open fractures, it's 24 hours when you can close the skin. So specifically also for the grade 1 and 2, but in all cases where skin closure is possible, and when not, then it's a maximum of 72 hours, and then everything will be stopped. And in our case, this means that in our center we had 500 patients, which we evaluated, and even when we give longer antibiotics, we saw that those cases were at a higher risk of developing an infection later on. So the answer is no.
Okay, could you please...
Can I comment here for that regimen? Does it apply for every single patient, or if we have a high-risk patient, for example, diabetic or has some immunocompromised, does that protocol apply or not? Because diabetic patients are, and especially at this site, is a little bit risky.
No, the principles stay the same. So also for diabetic cases, so the discussion is also always in PGI, but also in FRI, specifically in fracture-related infection, diabetic smoking, full stop. Specifically, I mean, Dr. Trampus can say more, but amoxiclav is absolutely, it's not an ideal antibiotic at this time to give for a prolonged period of time. You will not cover the bacteria you would like to cover on a longer period of time. So.
Okay, Dr. Andre, there is an evidence that prescribing an oral weak antibiotic itself could result in a chronicity of the infection and antibiotic resistance. Could you please explain this further?
Yeah, you are right when you call it a weak antibiotic. Amoxicillin and clavulanic acid is not well absorbed, and especially it doesn't go into the bone. So this is probably more counterproductive. And I agree, better would be not to give anything and see how the wound goes. But I understand also the fear. I mean, it was already not maybe a good idea to do an internal fixation. So we want to protect it. But then, yeah, it's definitely not this antibiotic which should be given. So I agree not to give it.
Okay, could you please explain to our colleagues? Yes.
Barakat, Dr. Trampus, how to choose our antibiotic? Now you have said that it doesn't have a good concentration in the bone. So what are the antibiotics of choice that have a very good concentration on bone?
Yeah, that's an important question, and we can discuss it also later. But I would give IV from the beginning for this first day 2 or 3, and that is either piperacillin plus tazobactam, tazocin, which covers almost all gram-negatives as well, or we can give also a cephalosporin plus gentamicin. That would be the second option, IV. But orally, I would not give at this stage. Just stop it after.
Which generation of cephalosporins, Dr. Trampus?
If you combine it with a gentamicin, then gentamicin is the coverage for the gram-negative. Then I would use the first or second generation, which means cefazolin or cefuroxime, IV.
So to sum up, you need to give antibiotics IV for 72 hours, first or second generation cephalosporins in addition to gentamicin.
1 to 3 days, yeah, depending on how good or bad the soft tissue is. Maybe Willem, would you like to comment on the duration IV?
Yeah, so for the low contaminated injuries in the Gustilo grade 1 and 2, the gentamicin or the aminoglycosides, also like tobramycin, it's not necessary. It's only in the grade 3s, and then indeed it's for 72 hours. But I think the message again is that in these cases you stop the antibiotics. And then follow, and if you have any suspicion, of course, you culture and do a surgical debridement, but at this time you stop the antibiotics.
Okay, Dr. Gebeli.
Excuse me, Professor Trampus. We have a belief in Egypt that garamycin and gentamicin and all these old gram-negatives are very weak. All of us are directed to the 4th generation cephalosporins. 4th generation, not the first, not the second. We think in another way, possibly because this gentamicin rare to find in our cultures. So we go for negative by the 4th generation cephalosporin and for the positive by something like vancomycin or targocin, ticoplanin, or whatever it is. But 1st generation cephalosporin is out of our scope, and the gentamicin is out of our scope. So what do you feel? Is every place had its organisms and its antibiotics, or because we have abuse for antibiotics here in our country? Or still you believe that we can use a 1st generation cephalosporin with gentamicin? Please.
If you have multi-resistant bacteria, then of course you need to go one step higher.
No, I'm speaking for empirical at the first 72 hours.
Yeah.
Not you didn't reach a multi-resistant bacteria. Okay.
Yeah, if your epidemiology shows that you have more resistant bacteria, so you need to change the empiric treatment already to cover those, then of course that would be vancomycin or teicoplanin to cover better the gram positives. And for the gram negatives, yeah, you can go for fourth generation of cephalosporin. That would be cefepime, but that's already your last resort. So I hope that the resistance is not so high that you need to give your best antibiotics already as an empirical, because then you will lose those as well.
Yes.
Gentamicin should cover, I think, 80 to 90% of your gram negatives.
Yes.
Okay, Dr. Gebeli, would you please proceed with the case?
I respect all the opinion that said that the wound looks angry and it's not the optimal case to do internal fixation, but we took the patient to the OR in the first 24 hours. We did aggressive debridement. There was no massive periosteal stripping, and we managed to close this wound primarily. So that what favored us to do internal fixation, and we did the internal fixation through a MIPO technique. And this is the condition of the wound directly after 2 weeks. The wound is still looking calm, and we managed to do it to close it primarily, not under tension, as you see. And we applied both plates with a minimally invasive technique, and we didn't do aggressive dissection. That's what makes us favoring to do internal fixation. But unfortunately, 2 weeks later, the patient developed pain, redness, and swelling, persistent wound hematoma, and bloody discharge. The white leukocytic count was almost normal. ESR in the first hour was 40, and CRP is 48. This is after 2 weeks. How can we diagnose infection now?
Okay, we have a poll questions for our attendees. Please, we have 10 seconds to take this question.
Baraka, please, I want to ask Velen about the, we have bypassed the first step. What you are going to do with this angry wound? Slab, fixator, spanning fixator, and you postpone your fixation, or you will do like what have done Professor Gebeli?
The previous slide, you mean? So at the first stage,
Yes.
in
Yes.
our case, we would use a classic spanning fixator, and if the wound is perfect, you could try and close, and otherwise use a temporary dressing or VAC. But the Wolf trial now shows that the VAC is not superior, so some kind of temporary aseptic dressing is fine.
So you will never fix. That's what I want to reach. You will never fix by this wound. You will never fix.
If I fix, and that's specifically, for example, in younger patients or in children even, then I would use a Elisoframe.
Yes.
Okay, Dr. Gebeli, would you please show us the surgical options?
What's your next step in management?
Yes, please forward one slide. Yes, that's it. Dr. Willem, many of our participants have chosen to observe only and to continue with antibiotics. I guess our problem here is that we cannot establish a diagnosis of infection. So do we have diagnostic criteria at this stage to define infection?
So you have different suggestive signs. I mean, you have pain, redness, swelling, the persistent wound drainage. You have an elevated CRP, although that in trauma patient is not saying a lot. In those cases, you have enough. I will show later suggestive signs that we have to look for confirmatory signs, so signs that define your infection. So this means in this case, we would look for confirmatory signs, and that only can be done by surgical exploration. There's one but, and that's the patient is still on antibiotics. And that's a discussion point because the chances are big that your cultures will stay negative. And I will also show later that in our hands, in our center, if possible, we would try and stop the antibiotics.
Okay, so your chosen best option is the surgical exploration for deep tissue samples.
Yes.
That's it? Okay.
Yes.
Dr. Gebeli, could you please forward one slide?
This is actually what we did. We decided to do immediate exploration. We did debridement, irrigation, and we see that the implant was still fixing the fracture properly and not loose. So we decided to retain the implant, and we take sampling for cultures.
Okay, Dr. Mahran, do we have a time-based classification for the biofilm to judge whether do we need or should we retain or should we remove the implant?
Thank you, Mustafa. Actually, we don't have a fixed time frame. You can, but the more you do, if you are in the first 3 weeks, you will be lean to leave the implant if they are stable. But the more time passes after surgery, this means that you have a mature biofilm and you really cannot keep your implant and you have to change it to another one. But I would say that my personal opinion is that should be guided by the maturity of the biofilm. And if we have 2 weeks has passed since the operation, this means that you have a mature biofilm, and the best course of action, in my opinion, was to remove the implant.
Okay, Dr. Willem, would you like to add something?
Yeah, Mustafa, can I add something here? We don't just depend upon the biofilm. Yes, biofilm is extremely important, and to mature biofilm needs 3 weeks at least. And so stability of the implants is important also, but the most important is the soft tissue coverage. So if I have a soft tissue coverage that is not that good, and I have some doubt about it, I have to remove the implant. So it doesn't depend only on one factor. There are many 2 factors that dictate us to remove or not.
All the factors mentioned, Professor Zahir, was really good. The adequate soft tissue coverage, the implant was fixing the fracture well. We are early in 2 weeks, so the biofilm was not developed. We thought that the biofilm was not developed yet. So that's why we decided to retain the implant.
Yeah, I'm just commenting when to remove the implant. So those are not just the biofilm.
Okay, Dr. Ibrahim, do you have a consensus regarding the irrigation fluid, and any additives, the pressure and the volume?
Regarding the irrigation fluid, in the trauma cases or in the fracture cases, according to the consensus, they prefer to use low grade or low pressure irrigation solution, normal saline, in contrary to the PJI or periprosthetic joint infection, where it's advised to use betadine, a diluted betadine. However, in the case of fractures, this betadine might be a little bit toxic to the osteoblasts, and that's why it's preferable to use normal saline without high pressure, low pressure wash. The volume is actually depending on the site of the infection, but you have to use copious amount of irrigation solution to dilute the infection or the organism there.
Okay, Dr. Mahran, is there any strict sampling protocol should we follow in order to increase the yield of the cultures, or just take any swabs or pieces of tissues?
Yes, Mustafa. The rules have been set long before. You have to obtain up to 5 samples. They have to be deep tissue samples. You should avoid the sinus tract and avoid using swabs. Yes, that's very important. 5 sample deep tissue samples taken immediately to the lab.
Okay.
And of course, you have to use separate instruments and change the drafts. And before that, you should avoid using the induction antibiotic before you take your samples. That's very important.
Okay, Dr. Willem, regarding the best place to obtain our specimen, from which site exactly of the wound? Should we take a screw or the implant or the bone implant interface, any bone spicules, tissues, fluids of the pus? Which one is the most sensitive to yield a positive culture?
Actually, all the ones you told us are adequate. If you have pus, of course, you take cultures of the pus, but the best places are the fracture site and the bone tissue interface. So those are the most optimal sites for taking cultures. And as already said previously, it's very important that no cultures are taken from the wound, the tissue, the soft tissue itself around the wound, or fistula, or using swabs. That's really a no-go.
Okay, Dr. Brahim, in the PGI, we could rely on the aspiration in order to confirm our infection. Does this apply to the FRI?
Unfortunately, no, it's not the same issue, and it's not even the same yielding chances. The aspiration or the needle or the puncturing of the wound or percutaneous puncturing does not yield organism that frequently. So it's advisable usually, as Dr. Mahran and Dr. Willem were saying, to have deep tissue cultures, preferably from the metal bone interface or the non-union interface. So we should not rely, we should not rely on aspiration. It has no role in the fracture setting.
So
this explains, Dr. Ibrahim explains why we have a lot of negative cultures, because the way we obtain our culture is sometimes wrong, to my mind.
Actually, we have a multitude of problems in obtaining the cultures in Egypt. Actually, from the beginning, from taking the cultures, from using antibiotic preoperatively. Like, for instance, this case, it was on antibiotic for 2 weeks, then went for debridement. So we have a very small chance to grow an organism. Also, the way of taking the cultures, as Dr. Mahran was saying. Also, then the media we use, transport to the lab, and the time frame to transport the media or the culture to the lab without contamination. We have a multitude of problems in Egypt to grow these organisms. Also, in most of the labs here in Egypt, we don't have the luxury of having an extended culture. It's usually read in 48 or 72 hours. So actually, we need to build a concept, or to convey the concept of having a proper culture and proper media according to different situations. And of course, we should have a multidisciplinary team to manage such cases, whether the PGI or the fracture-related infections.
Okay, Dr. Gebeli, could you please go forward?
Before going from this point, please, Dr. Zahir, I want to ask Professor Trampuz, is it mandatory to stop antibiotic before obtaining a culture? Is it mandatory to stop antibiotics as a routine words 4 to 5 days before holding the culture?
Yes. Can you hear me? I see that
yes, we can hear you very much.
The camera is maybe not, but this case is a perfect example that oral antibiotics were not sufficient to cure the infection, but it was enough sufficient that the cultures were negative. And that is definitely one thing which we can learn from this case. The second, which maybe I forgot to mention before, is that we should do sampling before any irrigation. So whenever you open the wound, first take the tissues for culture and then do the irrigation. Otherwise, the dilution will dilute also the microbiology yield. And sorry, your question was?
Well, is it mandatory to stop? If I have a virulent organism, I suppose that antibiotics is not able to deal with it. So why it is negative in my culture? So do I have to stop it 5 or 3 days at least before obtaining my culture?
It will probably not help much to stop it now because the wound doesn't look okay. So I would not wait only to keep the patient off antibiotics. If the wound doesn't look nice, I would go for revision and culturing independent if you took the antibiotics, yes or no. In elective revisions, when we have time, because for example, for pseudoarthrosis and non-union, then I have time to stop because it's a chronic situation. But in this case, I would go for revision as you did.
Yes.
Can I add something, Dr. Baraka, please? Dr. Amr, regarding your question, sometimes you cannot wait for 2 weeks to stop the antibiotic, but you have to tell the lab that the patient is on X and Y. Yeah, as long as you mention to the lab so that they considered it in the sensitivity report, so there is no problem, because sometimes you cannot stop it that long before going for debridement and culture sample. But just tell them that the patient is on blah, 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 blah.
Yes.
Yes, that helps indeed, especially that it maybe sensitize the microbiologist to prolong the cultivation. Because if patient is on antibiotics, maybe bacteria will grow, but they need longer than 7 or 8 days. Maybe they will grow on day 10 or 14. So I agree with you completely that the transportation is important, and also the long incubation of 14 days, as long as there is a foreign body in place.
Yeah,
Yes.
I have two questions to Trampus. First one. Now we are in second week, and the biofilm is about to form. So what to do to get rid of that biofilm? And the second question is regarding the sampling. Do we need to do sonication to these samples?
Do what? Do what? Do what,
Sonication.
yes, sir?
Sonication.
Sonication.
Sonication is a very good method if you remove any foreign body. In this case, probably you will retain it. So sonication has no place. You need to rely on tissue, several tissue from different places, specifically those which doesn't look nice or look inflamed. That was the sonication, and the first question was
Biofilm, how to get rid
Yes.
of the biofilm.
You're very right. At this point, we have a biofilm, but it's still less than 6 weeks, which is more or less the time, as mentioned before, where we can eradicate it. So after debridement, after the closure of the wound, and after we get, after a week or so, the right pathogen, then we can switch to biofilm active antibiotics. But at this stage, the most important task is how the wound gets closed and the infection controlled. We have still time to start biofilm active antibiotics orally later.
Okay, Dr.
So,
Andre, could you please?
Yeah, another question to Willem, because some of the papers have said if you are in doubt, you can remove that implant and put another implant, even after 2 weeks, so to avoid the formation of the biofilm. Does it work here or not?
No, all the papers actually, and there are not a lot, but I will show that later, show that at a time point within the first 3 weeks, if you have an adequate treatment, and this also means, of course, and that we have to see here, of course, you have adequate tissue cultures and good results, that you have antibiotics that work, but then you can retain the implant and you shouldn't do an exchange. There is no study showing anything on an acute exchange or an exchange in a very early setting in fracture-related infections. The studies, for example, by Zimmerli in the first 3 weeks showed that at that time you can retain the implant. Of course, I will show later there are a lot of other factors that also need to be taken into account. As you already said, very good. It's the soft tissue, it's the stability, it's the host, or a lot of other factors we have to take into account. But what we know now, it seems that the implant is stable, soft tissue is adequate. This time we can retain the implant.
Okay, for our participants, yes.
I have a comment and a clarification. There's a controversy regarding the use of the prophylactic dose of antibiotic before the incision. Most of the literature has shown that there's no difference if we give a prophylactic dose of antibiotic before incision. However, there is some kind of consensus that we should not give it that prophylactic dose because this might decrease the sensitivity of the culture or the yield of the culture. So, Willem, would you give an induction dose of antibiotic in such a case?
Yeah, Andre can answer to that as well. At time when you do a revision with a new implant or a second stage, we always give the antibiotics at induction. The question is a little bit also in chronic cases, and in these cases, if it's not necessary, we don't give them. But Andre, normally there are studies showing also in PGI that it will the the initial dose will not influence the cultures.
Yeah, exactly. I agree. As a general rule, whenever you implant something, you should give antibiotic prophylaxis 30 to 60 minutes before incision, usually at induction of the anesthesia. If you do revision and it's clearly infected, then actually you don't need to give prophylaxis. You will give anyway treatment afterwards. But if you don't know if it's infected or not, you can give the prophylaxis. Everything what you give within an hour before sampling will not make your cultures negative, because antibiotics take usually 24 hours to kill bacteria. So you can, in doubt, give the prophylaxis and you do the sampling. That will not influence it.
And a final thing, Dr. Gebeli, we should not forget patient optimization as we're going through the local management. If there are any issues to the general status of the patient, I think it should be optimized at the same time if he's diabetic, so on, so on, so on.
For sure.
Okay, Dr. Ibrahim, speaking of patients optimization, this patient was a smoker. So do we have a consensus in this respect? What to deal with smoker patients if we're faced during this stage?
The patient should stop smoking, period. He should stop smoking and for a long period of time, until we get wound healing and preferably bone healing also, because it has been shown beyond doubt that smoking might affect the vascularity and might affect healing.
This usually doesn't happen for every patient, Dr. Ibrahim.
I know, but at least we should say that he should stop smoking.
Okay, Dr. Gebeli, could you please continue with the case?
Regarding smoking, if you allow just one comment,
yes,
I absolutely agree. Already 4 to 6 weeks of ceasing smoking before surgery will dramatically lower the risk of infection. So definitely it should be at least mentioned. I agree with Professor Ibrahim.
May I ask a question, because I usually get that question. I don't have a solid answer. Does the alternatives of smoking, like the vaping or the IQOS or so on, have a different effect, or it does have the same effects compared to the conventional smoking?
That I don't know. Maybe somebody knows anything. I just saw the articles. Willem, maybe you know?
At the moment, there's not enough evidence to really comment on that. The studies with smoking are, of course, long-term, but we don't really have long-term results about vaping, actually. So it's difficult to. I normally suggest they really stop also vaping when it's really difficult. It's an option to switch, but for the moment, I would suggest, when possible. Of course, it's difficult, but when possible, to stop everything.
Okay, Dr. Gebeli, please proceed with the case.
2 weeks after debridement, the pain mildly improved. The wound edge started to be necrotic. Total leukocytic count started to increase from 8,000 to 10,000. ESR also increasing, but the CRP decreased to 36. As usual, the operative culture showed no growth, and the patient was given empirical oral linezolid.
Okay, Dr. Andre, no growth in cultures is an everyday problem that we really face like every day. The techniques to relieve the free bacteria, like the sonication, as Dr. Zahar mentioned, may increase the yield on the cultures.
Yeah, but at this stage again, you have nothing to sonicate because there was nothing removed. You can only, if you remove a metal part or a plastic part in joints. So at this stage, I would say it's a culture negative infection. We have enough suggestive signs. And I would start with empiric antibiotics, as it was done here.
Okay, however, what do you think on the prescribed oral antibiotic, or just oral linezolid?
Yeah, exactly. This is what I would not do, because it's always good to start with IV antibiotics, because intravenous, you will have much higher concentration, not only in the soft tissue, but also in the bone. And I would go for a broader. If, for example, before I would take cephalosporin and gentamicin or tazocin, then I would go now even one step higher, which is meropenem. and maybe vancomycin to cover both gram-negative and gram-positive, and see if it goes well without removal of the implant. So oral is only after 1 to 2 weeks of IV.
Okay, Dr. Gebeli, could you please proceed with the case?
4 weeks later, pain increased, wound is ulcerated with mild discharge. Total leukocytic count decreased again, ASR is decreasing, and the CRP decreased to 12. And we continued the same oral antibiotic.
Okay, Dr. Willem, in such a case where there is persistent discharge and there is a non-healing ulcer, is there any point to continue with the oral antibiotic?
No, if this patient, and it, of course, it's a weekly problem. Also, it's not only in Egypt but also in Belgium. That in these cases, the patient is not sick. He will come to the outpatient clinic, and we'll stop everything, and we'll plan him for surgery without antibiotics, if possible, even within 2 weeks. But at least we will try and wait a week. But actually, this is a perfect case where the attendants here can see that giving the antibiotics didn't do anything. It's still infected. So why give the antibiotics in the first place? It makes yourself maybe feel better, but it doesn't change the outcome. So I think here it's stop everything.
Okay, Dr. Gebeli, could you please go one slide forwards?
A moment, please. Dr. Trampuz, what do you think about linezolid here as a molecule?
Linezolid is the very small antibiotic, so it's very well absorbed, in contrast to the previous antibiotic, amoxicillin and clavulanic acid, but it's only bacteriostatic. There was in the chat also a question about clindamycin. Clindamycin and linezolid are both only bacteriostatic drugs, so we can use them for later. At this stage, we need something which is bactericidal, and this is IV, typically vancomycin or teicoplanin. Or I don't know if you have also fosfomycin IV. This would be one of the 3 drugs for gram-positives. But I would add also something for gram-negatives, which is gentamicin, for example.
Would you comment on the dose of vancomycin that you give the patient empirically?
Empirically, we give 2 times 1 gram. If the patient is, let's say, more than 90 kilograms of weight, you can give also 3 times 1 gram, so that you, after 2 or 3 days, you reach the therapeutic level.
You don't give a loading dose?
You can also go for a loading dose, which is the double, this is 2 grams, and then you continue every 12 hours with 1 gram. But if the kidney is not so good, for example, in diabetic patients, I would not start with the loading dose. In sepsis, you do it. In this soft tissue local infections, you don't need.
And you follow up the level of the vancomycin?
Yes, if you have, yeah, exactly. If you have the possibility, it would be good after 4 days to measure the level of vancomycin.
It's not mandatory.
It's not mandatory. In younger patients, it's enough to monitor kidney function. As long as the kidney is okay and you are giving good vancomycin dose, there is no need to measure the threshold. If you give teicoplanin or daptomycin, then you don't need to measure because you're always in a good range.
Okay, Dr. Willem, in this case, the CRP was declining the slide before. Would this be an index that the patient is improving?
No, specifically in chronic fracture-related infection, the CRP, ESR, and white blood cell count are not really indicative. They are suggestive, but they don't really help us with a definitive plan. It's more the clinical situation here that should guide treatment. Okay, there was a previous classification of fracture-related infection as superficial and deep. If the surgeons find the infection superficial and the wound cannot be directly probed down to the implant or to the bone surface, the surgeon reassures himself that this is a superficial infection that I can adequately control with antibiotics and dressings. We need to know where does this classification stands
in the recent FRI consensus?
It's in the bin. It's thrown away.
Okay.
It's something that's I'm really keen on because it happened here as well a few years ago. But we did also a lot of studies already. There are a few of them coming out where we compared to the CDC. Because what you mentioned is correct. It's the CDC guidelines on superficial and deep infection. Remember, the CDC guidelines were developed for general surgery, abdominal
yes.
surgery. They don't account for fracture-related infection. There's no specific guideline within it, although they try to mention it. But the superficial sign infection in this case, where the implant is 2 millimeters below the skin, it's bacteria don't see a barrier. It's 2 millimeters. It's in connection with the blade. So we often see patients refer to with a superficial infection, and the general practitioner or other colleagues from other centers say it's a superficial infection. But that doesn't exist specifically in those cases. For example, in the ankle and where the implant is so close to the skin, we always have to think this is a fracture-related infection. This is a deep infection.
Okay, Dr. Gebeli, please go ahead.
And this is, we continue telling ourselves that it is a superficial infection and that the ulcer is healing with the linezolid oral. And we waited for 3 months, but the pain is continued and the ulcer still not healed. And also the fracture is not united. White BC is 6,000, ESR is 30, CRP is still decreasing. So we're still convincing ourselves that the infection is controlling and this is only a superficial ulcer which will heal. And this is the current situation after 3 months.
Okay, Dr.
Can I ask here a question? The color of the skin, does it indicate anything here, or if we have that color around the ulcer, does it mean anything here, or does it give us a clue? What do you think, Dr. Villa?
For me, not personally. I think I'm more concerned about the fistula themselves. Probably you always have to think about the fact that the patient has vascular insufficiency, and we have to check that. Of course, that's something else as a smoker, and so that's really important. So that part, yes, but I would primarily be concerned about the ulcer section.
I think that the ulcer and the color of the skin is improving, Professor Zahir, from this situation in 6 weeks. And now after 3 months, so it is, I think it's getting better.
So what does it mean, having this discoloration? That was my question.
Yeah.
If I may also add, the first, if you give oral antibiotics which do not affect biofilm, and this is linezolid, it has no effect on biofilm, you will heal the soft tissue. So soft tissues may look better, but there is still a chronic infection implant associated below that. And the second point, the CRP, as long as the wound is open and is oozing out, the CRP will fall down, but there is an infection. So CRP in a non-dry wound is always misleading because it gives you the impression it's better, but it's not.
Okay, thank you, Dr. Trampus. Dr. Gebeli, please launch our question.
What's your next step in management? Debrided with implant retention, debrided implant retention and bone grafting, debrided implant removal, external fixation, continue with antibiotics. Okay,
Dr. Willem, there is a term which is suppressive antibiotics that's often used inappropriately in many cases. Do we have any criteria to apply this term correctly? Which cases should we give the suppressive antibiotics?
Professor Trampus will elaborate on that later, but the suppressive antibiotics are more focused on difficult to treat infections. What does that mean? A difficult to treat infection is an infection where you don't have antibiotics that are active against the biofilm, meaning rifampin in staph infections and fluoroquinolones in gram-negative infections. And when you don't have those antibiotics, we say the treatment is merely suppressive. So at the time the fracture is healed, you can remove the implant.
But can we go for suppressive antibiotic without identifying the organism? We have a negative culture so far.
Sorry? So
can we go for a suppressive antibiotic?
Absolutely not.
Without identifying the organism?
Good point. There is no culture at the moment, so you can't go for suppressive therapy here. It's impossible. Specifically not after 3 months. It's a chronic infection.
And specifically that the wound is not completely nice. Suppression is only then if after surgery the soft tissues are perfect and you suppress until the bone heals. But here the bone will not heal.
Okay, most of our participants have chosen option C, which is to debride, to remove the implant and to go for external fixation. Dr. Gebeli, could you please show us what happened next?
This is what we did. We did open debridement. We removed the implant, and there was a 2.5 centimeter of dead bone under the plate with no signs of healing at all. We did resection for this necrotic segment, and we did sampling for culture. And we applied Elizarov external fixation with a compression distraction method. And 4 months later, the frame was removed and the wound was healed and the fracture was united. Okay,
Dr. Gebeli, could you please go back one slide? Okay, Dr. Willem, based on the biofilm maturity at this stage, is there any role for implant retention? Could we leave the implant?
No, absolutely not. No. So you have an infection that's 3 months old. You have a bad soft tissue status, and both are key factors. And probably here, because the fracture is not healed, you couldn't see it on the X-ray, but probably there's also instability at the moment. So no, at this time, no place for it there.
Okay, there could be an argument regarding this segment resection. Many would argue that this is not an infected bone, it's just a necrotic bone or an atrophic non-union. Can we differentiate between both?
No, you cannot differentiate, but to be honest, if you have a fistula that's there now for 3 months and you have that bone, it's infected. So it's definitive. And at that time, you need to see at which point the bone starts bleeding again. And I think here 2.5, 3 centimeter resection is fine.
Okay. Dr. Gebeli, could you please go one slide forward? Okay, regarding the antibiotic used during the Elizarov external fixation, many surgeons wouldn't give any antibiotics at all, while others would continue till after the Elizarov removal. Do we have a consensus in this respect?
There's not a lot of consensus when the ED frame is on. So if you do a segment resection and you have a good soft tissue status and healthy bone, a maximum of 2 weeks is stated in our consensus papers, but there are not a lot of studies saying anything. And indeed, there are a lot of colleagues, they would prefer not to give antibiotics. But so with a maximum of 2 weeks, and the 2 weeks would be just for soft tissue infection. Again, there are not a lot of studies that publish data on antibiotics and ELI frames. I believe that in these cases, normally you did a segment resection, the soft tissue is good, the implant is removed, a maximum of 2 weeks is normally enough. Only then when you really have an expected intramedullary infection or an osteomyelitis in a severe septic case, that's something else.
Okay, I guess that's the end of our case.
Dr. Willem, there is a say here. I don't know about it, but I am not an Elizarov guy. That applying an Elizarov infection burns the infection. Is that true?
Yeah. So that's the old Elizarov textbook where Dr. Elizarov himself stated that, and I think somewhere the principles we understand now and indeed agree upon. If you see on specifically transport cases and infection, and interestingly, we don't have a lot of literature, so it's just by saying. But yeah.
Okay, and there is a question for Andre here about the role of rifampicin here in this case for the biofilm. And
yeah, thank you. I saw it and I also responded that rifampin, but I think it's very important to mention, has nothing to do in this situation. So rifampin is only when the infection is acute, so first few weeks old. The soft tissue is intact, so there is no situation like here. And we know that it's a staphylococcus, which is susceptible. So only with these three, then we give rifampin orally in combination with another antibiotic to prevent development of resistance in order to save it. And we know that this works in joint prosthesis, but also in osteosynthesis, but only in this situation.
Thank you.
Would you elaborate a little bit more about rifampin? How does it work? For how long do you give it? And when do you start it?
Yeah, very good point. Rifampin we should only give when the wound is dry, when we have a CRP, if we measure it, is also normal. And then we give it for at least 6 weeks. Some people give it even for 12 weeks, depending on the local situation. If we see that it goes very quickly, everything okay, we can stop it after 6 weeks. Otherwise, we continue for 12, which depends also on the size of the implant. And if I can comment on the previous question, when there is an Ilisaro, an external fixator, usually there is an osteomyelitis still inside. That was the reason why the external fixator was put. And in that case, I would give antibiotics for at least 2 weeks, maybe 4.
Yeah, I think that's a good point, Andre. So if you have a septic case or you really have clear signs of an osteomyelitis, we personally like to tend to give it a little bit longer. I have to be honest that there are not a lot of studies in the ILI cases, and specifically in transports. It seems that indeed the infection is treated by resection, removal of the implant, and, for example, starting the transport. And long-term antibiotics are often not necessary, like standard treatment of 6 to 12 weeks. It's not necessary.
Willem, do we need to do any other investigations as regards radiology, for example?
No, in these cases, no. In these cases, you have I will show it. You have a confirmatory sign of infection with a fistula present. Of course, you like standard X-ray also to look at stability. Sometimes you will do a CT scan to look at the healing, but no nuclear imaging scans, no MRI. In this case, it's relatively straightforward, and it is not necessary.
So when to do it? When would you?
When you're in doubt, that means that if you have a chronic case without confirmatory signs on the outpatient clinic, then you could ask for a nuclear imaging scan just to have another suggestive sign before you go to surgery. And specifically, the PET-CT sometimes helps with surgical planning. But I have to be honest, it's a little bit of shift now that where we had a few years ago, everybody got a white blood cell scan or FDG PET. It's becoming less and less.
If I may add, also there was a question in the chat if local antibiotics would help at this stage. And I think definitely yes, but not as suggested here in non-resorbable beads, because the PMMA beads will act as a new foreign material. So if you use local antibiotics, I would rather suggest in resorbable material. Willem, I think you wrote an article on that, right?
Yeah, I fully agree. The Genta pearls, so the beads are not used anymore. To be honest, in my own practice, I have to get them out almost on a monthly basis from colleagues 5 to 10 years ago with a low-grade infection, because at the time they give antibiotics for a shorter period of time, but when the antibiotics have been released, it's a foreign body. So I wouldn't use it here. No.
Can we make these beads by ourselves by the bone cement, and we cut it to beads, small beads?
That is an option. There is data in the open fracture situation.
Okay.
There's a systematic review showing in the open fracture situation, the acute situation, yes, you can use local antibiotics like the bead pouch, but we all know it's temporary.
Yeah.
But there it seems to have a good effect and have a significant reduction of infection. But again, the data is not really good, but systematic review and bone and joint research from us, I think 3 years ago, showed a significant reduction of infection in the acute fracture situation. In fracture-related infection, the data is not really strong, but I agree with On that PMMA or PMMA beads in this situation I would not use.
In acute open wound, would you go for would you try to close the wound primarily, or you don't like to do that?
In this case, I didn't really think the wound was ideal to close. So in this grade 3 open injury, I would not have closed the wound. I would use the local antibiotics, span, and plan the second stage.
Local antibiotics.
What about the wash with garamycin? Some surgeons use to make wash with garamycin.
So to wash it out with local antibiotics, yes. You mean?
Yes.
No, we used to do that with rifampin or and that's all stopped because it's locally toxic, and washing out with saline is better. If you want to use local antibiotics, I would suggest you try to use anything that gives you a slow release over the course of time, and not something like a very short washout.
As Willem mentioned here, the solution to pollution is dilution. So best is really with the volume to dilute the bacteria. But maybe gentamicin, if you use it in a fleece, in something which is resorbed, that could have an advantage because it stays there for a longer time. If you use it only as a washing, then it will not have time to kill, because antibiotics needs at least 24, usually 48 hours to kill bacteria.
Yes. Yes.
Okay, now it's a pleasure to have a presentation of the evidence by Dr. Willem Metzmakers. Dr. Willem, could you please share your slides?
Yes.
مصطفى عرف ان هما الاثنين كانوا في الكونسنسس الاخراني هما كانوا فيها مع ذلك.
Can you see my screen?
Yes, yes.
Okay. So of course we can fill a whole day only just talking about the consensus recommendations, but I will try and just give you a short overview. And actually a lot of the stuff is already discussed previously, so that's of course really good. So let's shortly discuss the diagnostic criteria and the definition for fracture-related infection. And it's actually been developed by a consensus group a few years ago. And it was decided that there should only be a single definition. So we don't subdivide anymore in acute and chronic fracture-related infection with respect to the definition itself. And as already stated, there's no subdivision anymore. So there's no subdivision in superficial or deep or any other anatomical locations. And I'm very happy to hear here that we use only the term fracture-related infection, in contrary to, for example, periprosthetic joint infection, PGI, we now use FRI, also in all published literature. So there are two levels of certainty. We have the confirmatory signs, so we mean infection is definitively present, or we have suggestive signs. We have 5 confirmatory signs and a list of suggestive signs that lead us or should lead us to further investigation. What are the confirmatory signs? The fistula, the sinus, the root breakdown. In these cases, the infection is definitively present. When you see the implant, it's an infection. That's really important. For example, in this case, the implant is visible and it was a staph epi infection. Clear pus, also a confirmatory sign of infection. Of course, our microbiology is important. When we have pathogens identified by culture from at least 2 deep tissue deep tissue or implant specimens, we have the presence of an infection. And I think it's important to just shortly show, and this is a paper focused on fracture-related infection, what is important when we look at microbiology. So most of the sampling protocols have previously already been validated in other implant-associated infections like PGI. We try and stop the antibiotics, specifically, as Andre said, in the elective cases. Of course, in the acute cases, this is not always possible. Preferably, we take 5 or more deep tissue samples, ideally from the implant or bone interface. It's recommended that we don't manipulate the target area, so we use a no-touch technique with unused surgical instruments for every sample we take. And we don't take samples from the skin or the sinus tract, and it's very important that we don't use swabs, specifically not on the outpatient clinic. We don't use swabs on the emergency department, but also not in the OR because they have a low yield compared to tissue cultures. Histopathology, it's also often used. We didn't talk about that, but the presence of microorganisms, but more specifically with staining techniques like fungi, for example, here it's a confirmatory sign. But also in non-union cases or in the chronic infected cases, the presence of more than 5 polymorphonuclears can be confirmatory for infection. Some of the suggestive signs you already, of course, know. The clinical signs are radiological signs. Think about non-union. Imaging in general, it's interesting, but it's more like a suggestive criteria. So based on the best available evidence of the last 2 decades, there is not a lot of evidence. When we look at white blood cell scintigraphy and FDG PET, they show a high accuracy for detecting FRI, but they can only be seen as a suggestive sign. So they cannot be seen as a confirmatory case, not in acute and also not in chronic cases. And then the last suggestive criteria are the pathogenic organism identified by culture from a single deep tissue culture. Of course, when you have a high virulent bacteria like a Staph aureus, there's a high suspicion of infection, specifically when we use sonication, for example. In cases of an elevated serum inflammatory marker, it's only a suggestive criteria. There are studies already shown that, specifically in chronic cases. Persistent or increasing wound drainage, but also the new onset of joint effusion in fracture patients can be a sign of infection. These are the 2 studies, the 2 papers that have been published on the topic. And this is then the flow diagram that we developed together with other scientific organizations, but also the Pro-Implant Foundation. And then it's important that we try and follow this diagnostic algorithm. And then often the question comes on, what if we have on the outpatient clinic only these suggestive signs, for example? We have to consider then the presence, like in this case, for example, that there is an FRI, and we look for confirmatory signs. And how do we do that? That is with a surgical exploration. And finally, I would like to end with some general treatment principles for fracture-related infection. And these can be found in this paper, also a consensus paper on the general treatment principles. And it's actually following a standardized approach, also a flow diagram from the first patient contact. We start, of course, as we already saw in our case, with a well performed workup, and we'll look for the diagnosis of fracture-related infection. Then when we have a confirmed or suspected FRI, we have to assess the patient. We have to assess soft tissue status and neurovascular status, perform a baseline blood analysis, but as you already said earlier, also start patient optimization. For example, talk with the patient, say he needs to stop smoking, look at his diabetes status, etc. First and second, it's really important that we stress here the implementation of a multidisciplinary team approach. This is why often Professor Trampus and myself talk together. We're a team. We address the patients as a team. And this is really shown to improve patient care also on the long term. Minimum of 3 disciplines should be involved. These are the surgeons, the ID physicians, and the clinical pharmacists. But this is different in every hospital. And important also is what we're trying to implement is that if you have the very difficult cases, they should be sent to specialized centers where we have the presence of an MDT and physicians are experienced in the treatment of fracture-related infection, because we all know that volume performance is true with many complex procedures. Then, of course, when we have our treatment plan, we start our surgical treatment. soft tissue sampling, debridement, look at fracture stabilization, but also very important is the soft tissue coverage. And we have to discuss the two main surgical principles, and Professor Trampus will talk about the two main antimicrobial principles. And what are the two main surgical principles? First, we can retain the implant, do a DARE approach. The second is we can remove or exchange the implant. The question is, when should we do what? First, we have to decide what are our primary aims. So we go for fracture consolidation, restoration of function, and at the end, of course, eradication of the infection. And this is in contrast with PGI, because in fracture-related infection, the implant can be removed after consolidation. So complete eradication of the infection is not always our primary goal. What is then the treatment algorithm? We look at a first step, and that's, is the fracture healed? When the fracture is healed, we can remove the implant. But when the fracture is not healed, we have to decide, are we going for exchange or retainment of the implant? And then the question comes, okay, but what is the time interval which we can decide to exchange or retain the implant? Is it 4 weeks? Is it 6 weeks? Is it 12 weeks? And the problem is, studies show there's no robust evidence to show any or support any time-related cutoff to be a single deciding factor that influences our decision. And this is actually a paper that we recently published in a systematic review that looked at the influence of duration, so on biofilm formation in FRI and the influence it has on the outcome in the DARE procedures, so when we retain the implant. And here you can actually see that within the first 3 weeks, chances are extremely high if you, of course, also use the adequate antibiotics, you have adequate cultures and outcome, that the success rate is high, and it drops to 67% after 10 to 12 weeks, but not to 0. So there's no specific time cutoff point where we can say at this moment we can retain the implant, or at this moment we need to exchange the implant. So within 3 weeks, success rates are 90%. After 6 weeks, they drop to 70%, and they go to 50% after 10 weeks. And this is, of course, due to the chronicity of the biofilm. So what are now the other factors that influence our treatment decision-making? First is the time interval. Biofilm formation is, of course, still important, but it's not the only deciding factor. It's also stability of the construct. The question is there sufficient debridement possible? Severity of infection, fracture localization, but also the condition of the soft tissue envelope and the host physiology. So here we see the osteosynthetic construct, so the stability. Here we're loosening of the plate is very important. An unstable construct is a very bad situation, and here this is a paper recently published in Injury. It shows the viscous cycle of instability, where you actually promote osteolysis and further instability by bacterial proliferation at the moment that the fracture is unstable. So a stable local environment is really crucial. But also an important point is the question you have to ask yourself, is there sufficient debridement possible? In cases of a nail, this is difficult. So you need to ask yourself the question, maybe I need to remove it to have a better option to debride. And other factors, soft tissue envelope, fracture localization, but also the host physiology. So with this, we come to our end. And that is a paper from Professor Trampus and myself. And actually here we try and combine everything together in a treatment algorithm. As already stated, when you remove the implant, you go for a standard osteomyelitis treatment. It's antibiotics 4 to 6 weeks. And in cases where the fracture hasn't healed, you need to look at, is implant retention advisable? But here we don't only look at the time interval. We look at construct stability, at the host physiology, at the anatomical location, etc. And then Professor Trampus will talk about that later. We also have to ask ourselves the question, is it a difficult to treat infection? Can we treat the biofilm on top of the implant? And so with this, we come to our end. And of course, it's important after the surgical treatment that we have a correct empirical antibiotic treatment. And we discussed it with our multidisciplinary team. And I also want to stress that when possible, we have to follow the patient as long as possible. We try to do it at least 12 months till cessation of therapy. And we now use PROMISE, so the patient-reported outcome measure system, as a questionnaire for the patients when they come back to the outpatient clinic. So a take-home message: a well-established diagnosis is important, patient assessment and optimization, use an MDT approach, develop the treatment plan together within the MDT, follow for 12 months and use the PROMISE. And this would also help you with scientific studies, for example, that you would like to publish. So with this, thank you for your attention, and we hope to see you soon in person again.
Okay, thank you so much, Dr. Willem, for your valuable presentation. We've got a few questions that we did not address during our discussion. Dr. Zahar, what's the evidence for the use of the VAC dressings of the negative pressure wound therapy routinely for every wound after surgical debridement? So do we have a consensus or an evidence for this?
Yeah, so that's the last paper we actually currently writing, and we also performing a systematic review. The problem is with VAC dressings for a short period of time, meaning for a maximum of 7 to 10 days, it is okay. But the longer you give it, the higher the chances of recurrence. So we did it now in a large series of patients, and long-term VAC dressings, specifically in FRI cases, should never be done. You see the number of recurrence really skyrockets, specifically if you go beyond 2 to 3 weeks. So a short period of VAC dressing, it's fine, but not long-term. And in open fractures, it's actually shown now in the Wolf trial, it's not superior, it's expensive. So yes, we use it because it's easy to use for maximum of a week, but long-term use, also not in open fractures, it's a no-go.
Okay, thank you so much, Dr. Willem. We have another question about the local antibiotic delivery by the resorbable antibiotic carriers like calcium sulfate. What's their role in the local antibiotic delivery? And are they real substitutes to good deployment and the proper decision on the implant retention versus removal?
Yeah,
do they
I'm happy.
All the job in the infection eradication?
No, I'm happy with a comment. So local antibiotics are not a substitute for the well-performed debridement. And that's the most important point, is a well-debrided area, surgical area. Irrigation is very important, and a good soft tissue coverage is still the most important point. And if you have a dead space, then yes, indeed, local antibiotics can add in the treatment decision-making here and can be used. But I think one day in the outpatient clinic, for example, here, will show you that local antibiotics are not the holy grail. For example, we see femurs that have been stuffed with calcium sulfate and stuffed with bioglass, and they all recur. They all have they're all infected because they were not well debrided. So it's not a substitute. You can use it, but after a well-performed debridement.
Okay, thank you. I guess that's all for our first session.
Willem, please, last question, please. Is there any role for, after good debridement, for suction irrigation, possibly with something like Plafine? Suction irrigation?
A drain after surgery, you mean?
No, I mean you irrigate from one portal and suck from another portal.
Oh, on the
continue
ward
for 3 days. Yes. No.
Yeah, no.
On the ward, yes. Yes. In the ward, yes. On the ward.
Yeah. That's a good question. That's something that's been done here as well over the course of the years. But now locally we stopped it because we saw actually in our own case series here, it's not an additive. It often creates also, you need to be a little bit careful with wound problems, and so no, we don't do that anymore. Good surgical debridement, irrigation during surgery, that's enough.
That's enough. Thank you.
Okay, thank you, Dr. Willem. Dr. Mansour, could you please share your screen to start our next session?
Thank you, Dr. Willem. It is an outstanding presentation. Thank you very much.
Good evening, everyone, my esteemed colleagues and professors and guests. What a wonderful presentation and extremely important points that have been made. I hope this session will elaborate more on further points to be made concerning infection-related infection. In this session, we're going to try to outline surgical strategies to treat FRIs. We're going to discuss the importance of stability in infection-related infections and to outline appropriate use of antibiotics, which we all need to learn, define the role of all local antibiotic delivery. So this is the case of a 26-year-old male patient. He's a non-smoker, had a motorcycle accident and was treated and suffered a Gustalo 2 open fracture femur, was treated with an LRS as an external fixator for damage control.
Dr. Gebeli, could you please comment on this temporary X-fix? Would it risk a later infection? Do we really need all those pins?
For sure, this is not the proper management for a temporary X-fix. He used a lot of pins. The pins are so close from the fracture site. The pins are close from the definitive internal fixation site. All this will risk the potential of infection after definitive management. This is not the proper implant used as a temporary X-fix for sure. He didn't fulfill any of the principles for temporary external fixation.
Okay, thank you, Dr. Masroor. Please go ahead with the case.
So 2 months later, the surgeon decided to convert the external fixator with an internal intermedullary fixation as definite treatment in a single stage. He removed the X-fix and applied the intermedullary nail in a single stage. The patient was kept on oral antibiotics for another 2 weeks after his surgery.
Okay, let's have a pause at this stage. Dr. Ibrahim, do you consider this to be a safe conversion from the temporary X-fix to the definitive fixation?
Definitely no. As Dr. Gebeli was saying, this was a temporary fixator. It was left for a very long time. 2 months is longer than expected. And a one-stage conversion, I guess, might have a higher risk, a much higher risk for infection. So either to go for a shorter period of temporary fixation, 10 days to 2 weeks, then we can go for a single stage, or we'll go for a 2-stage exchange with an intermediate stage in between. Maybe you can use some traction and so on until we're sure that we don't have a pin track infection.
Okay, thank you, Dr. Andre. In this case, the surgeon was, he had a fear that he could risk a later infection because of this unsafe conversion. So he's kept his patient on 2 weeks oral antibiotics. Would this really help to prevent a later infection?
I think the important question is, was there an infection at the time when the nail was put in? So if the cultures would be positive, I would at this stage indeed start with antibiotics, but as before, the first week or 2, I would give IV, and then I would switch on oral treatment, but continue then for a total of at least 6 weeks with the biofilm activity. Just giving for 2 weeks oral, this will probably not help. So either we give for full antibiotic treatment if we think it's an infection, or we should not give anything. 2 weeks doesn't bring much.
Okay, thank you. Dr. Mahran, do you have a protocol for a safe conversion from the X-fix to definitive internal fixation regarding the exchange of the pins, the cultures, the timing? What do you recommend?
Actually, it's not a protocol, Mustafa, but it's a general agreement that if an X-fix is left for more than 2 weeks, that means that you have high incidence of infection if you convert it acutely. So there is a common consensus, and it was developed in Aachen University from Germany, that you can do safe conversion within 10 days to 2 weeks. But you'll have to debride your pin sites, change your draps, and then proceed with internal fixation. But if you are obliged to wait more than 2 weeks to do this conversion, it's better to be done as a 2-stage conversion.
Or we can go directly for a definitive external fixation.
or you can do as directly as an external fixation. Okay.
Okay. Okay, Dr. Mansour, could you please proceed with the case?
Okay.
Baraka, I'd like to ask Mahran هنا حاجة. For fracture femur, do you prefer to do the two-stage technique, because leaving a patient with his fracture, once you remove the external fixator and leave it without fracture, that's something.
No, Dr. Zahar. If you are asking me if a patient referred to me being in more than 2 weeks in a damage control fixator, I would convert him to a definitive external fixation, not do a waiting period and do internal fixation.
Exactly. So it's better, yeah.
Yes, yes.
Okay, Dr. Mansour.
2 months later, after the conversion into an intermedullary nail, a sinus developed at the distal locking screw with apparent discharge. And let's ask some questions to the attendees. So, would you continue to use suppressive antibiotics? Would you remove the distal screw only and debride at the site of the distal screw? Or would you remove the whole nail and debride?
Okay, Dr. Willem, in this case, do we need more confirmatory criteria to diagnose infection? In this case, we have the sinus and the purulent discharge.
So that's a confirmatory sign of infection. It's an often forgotten point, and people think, oh, it's maybe something small, it's not important. But if you have a sign, it's a connection with the implant. This means you have a fracture-related infection, and it's not only locally. It's through the whole intramedullary canal.
Okay, so just removal of the distal screws will not help to eradicate this infection, right?
No, and it's actually a problem we see often with referral cases where they only also in the tibia remove the screw which drained. And often see even cases where they close the wound again or using the tibia flap and then it comes back draining. And no, the whole implant needs to be removed.
Thank you. I guess this is a good point to be clarified, because a few of our participants have chosen to remove the distal screws only. We have to clarify that the infection over intramedullary nails is along the industrial surface, along the whole medulla of the bone. It only trickles down by the gravity through the distal locking screws. So we have to remove the whole nail, right?
Correct. Yeah, absolutely correct.
Okay. Dr. Mansour, please go forward with our case.
And this is what the surgeon had done. The surgeon decided to remove the broken screw, the distal broken screw, debride the sinus, and that led to a vascular malalignment and, of course, persistent discharge. His white blood count was 5,500, his ESR was 70, and his CRP was 12. So, what is your next step? A, suppressive antibiotic to fracture healing, debride single stage exchange of intermedullary nail, C, debridement and two-stage exchange nail.
Okay, Dr. Ibrahim, what do you think? What's wrong with this case?
في حد عنده دوشة شوية يا جماعة لو سمحتوا.
Actually, Baraka, as you were saying, everything went wrong from A to Z. They used an external fixator as a temporary fixator with so many pins. It was left there for 2 months. Then one stage exchange. Then the patient got infected as expected. Then they did exactly what you said, or what Dr. Willem was saying. They removed the distal locking screw that went into bulgus. So everything, actually every step was going against the odds. So now we have an infected, non-united distal femoral fracture. And I think we have only 1 of 2 chances, either to go for 1 or 2 stage exchange of the nail, or maybe exchange to an X-fix.
Okay, so most of our participants have chosen to go for a 2-stage exchange. Regarding how to select the surgical strategy, What are the criteria for a single stage exchange?
A single stage or two stage, you mean?
A single stage.
For a single stage, the most important criteria for me is to have an isolated organism. So you have to have a culture with an isolated organism, and that for now we don't have. So I think it would be safer to go for a two-stage exchange.
Okay, thank you, Dr. Willem. Is it applicable clinically or technically to have a culture in this case to go for a single stage exchange? How could we obtain deep samples to go for single stage?
There's no option in trauma cases. There's no option. We sometimes see people taking bone cultures or puncturing. The yield is too low, so it's extremely low even. So I would never do that. This is the case for two-stage exchange. There are not a lot of studies in trauma on one or two-stage exchange. There's one from Helfred from HSS where they performed single-stage exchanges in cases where there were no signs of infection, and they were infected looking backwards because of positive cultures, and they had a recurrence rate of, I think, approximately 20%, 20 to 25%, which is actually high. This is a fistula. This means that the case that you have recurrence is even much higher. So I would never, in cases where you have a fistula, never do a single stage at the moment.
Okay,
I would, if you allow it, also to just support this, that more than pathogen, more than microbiology, is important soft tissue. If soft tissue are bad, I would never go for one stage, because probably every third case, if not more, will fail.
In trauma, this is really important. Sometimes you get questions about PGI studies, but the trauma cases is different. And as Andre stated, soft tissue is really important here.
Actually, Willem, what you're saying is very true with the PGI. You cannot go for a single stage PGI unless you have identified the organism. Not only identified the organism, you have an antibiotic sensitive organism. You have you have good soft tissue coverage, and you don't have a sinus. So actually, the 3 points count. And here we don't have an organism. We have a sinus. The soft tissue might not be that bad. However, we have 2 of the 3 criteria that are not met. So I think it's much safer to go for a two-stage exchange.
Agree. Yeah.
Okay, Dr. Masoud.
Can I ask Willem why in PGI it is a debatable subject, while in trauma is not a debatable subject? You will go for two-stage.
No, it's like Dr. Iwam said, it's not really debatable, but of course there are much more studies on single-stage exchange when you have a good soft tissue status and you have puncture preoperatively where you have a positive culture. So there's much more evidence. In cases in trauma, you don't puncture soft tissue status. I would debate is even more important, and there are no studies. So at the moment, there's not really a debate. The only thing I meant with that is that there's just more studies, and you have the possibility of puncturing, specifically in hip and knee.
Yeah. And maybe I can add for the PJI that actually we don't require to know the pathogen before going to one stage exchange, because everything we will do the same. If you know the pathogen or not, we will start with the broad antibiotic treatment, and when we get the pathogen from the intraoperative samples or sonication, then we switch to the biofilm active antibiotics. The only thing is, if somebody was several times already operated and we expect a multi-resistant pathogen, then we will not go for one stage. Or if the bone is bad, that would be another reason to go for two-stage. Or if you couldn't debride very well, that would also change to two-stage.
Okay. Yes. Dr. Mahran, in this case, there could be an argument whether we should explore the fracture sites or just go for intramedullary debridement. Are there any imaging that could clarify this further?
Mustafa, this is a very debatable issue that we have been talking about in a lot of cases that we meet together. Well, if this nail was inserted in an open technique, meaning that the fractured site was open to be used for reduction, and then the nail inserted, then there is a high possibility that the surgeon has manipulated the soft tissue at the fracture site, and there is possibility of a local necrotic bony segment. This is different from having a case of a closed nailing. If you have a case of closed nailing, then you know that the fracture site was not devitalized. And we have faced many cases like this in the tibia, where we went on and managed this as an intramedullary infection. And after failure, we have realized that we have 5 or 10 centimeter necrotic segment. And then we had to go again and do segment resection and bone transport. So specifically, my answer to your question, if this was an open nailing technique, I would definitely open the fracture site. Why? Not only debriding the medulla, I would open the fracture site to make sure that the bone at the fracture site is viable. If this was a closed nailing, I wouldn't bother opening the fracture site, but I would go for intramedullary reaming and irrigation.
Okay, thank you. Dr. Willem, you mentioned in your presentation that intramedullary nails are difficult to debride implants. So if this infection was as early as 2 weeks, what's your surgical strategy? Should we also remove this nail?
In this case, I would remove the nail. You have a fistula, you have a draining wound. The surgeon already tried to treat it locally. In this case, yes, the nail would be removed. You're not able to debride the canal. It's an open fracture case. The nail needs to come out. There's also no real stability. You have the breakage of the distal locking screws. So remove it.
Okay, Dr. Mansour, could you please go ahead?
So after the case was presented this way, we decided to go for a 2-stage exchange nailing. The first stage consisted of the implant removal, intramedullary reaming and irrigation of all industrial necrotic tissue. We inserted an antibiotic-loaded cement rod into the medulla and took, of course, multiple samples for cultures.
Could you please go back one slide? Okay, Dr. Willem, as we know that intramedullary infections are difficult to debride. What are your tips to debride infected intramedullary nails? How much over-reaming is enough? How to clean the sites of the infected smaller screws?
So what we indeed do, remove the locking screws, remove the nail. I personally don't often really over drill too much the locking screws. I would really try and curette more the locking screws. You can use a drill, but I also with heat I would be a little bit careful. So curette the locking screws. For the debridement of the canal, it depends on how thick the nail is. You always try, normally it has been over-reamed 1.5 millimeters standard, so I would at least go a half or 1 on top of it. Depends also on the quality of the bone, of course. And in our case, but the data is not really strong at the moment, but we use a RIA system, reamer irrigating aspirating system. It's expensive, I agree. But the issue is that it can clean and syringe the canal out also distally. So that's something we use. But to be honest, the data on that it's not really strong at the moment. So if you have a good reaming system, you just over-ream enough and clean out with sterile fluid. It's enough.
Okay, in this case,
in such a scenario, wouldn't you use a low pressure pastille lavage? You know the pastille lavage?
Yeah, so what we use is the reamer, the RIA system. It's really low pressure. It's not pulsatile, but it's a low pressure device. I personally think the pulsatile, if you use it, the systems, it's not really necessary, but if that brings the water in the canal, it's fine. But I would always be very careful and use a low pressure device. I would never use a high pressure device here. And I know sometimes that happens, but I would never do that, specifically not septic cases.
Okay, in this case, the surgeon have chosen the intramedullary cement rod for post-debridement stability. And another alternative is to use a temporary X-fix for 1 or 2 or 3 weeks. Do you have a preference during two-stage exchange?
Yeah, so over the course of the past decade, we stopped using the X-fix because we saw more recurrence. Specifically, let's say something happens or the patient is not really good, and then the problem is that the X-fix doesn't stay on for 2 weeks or 10 days, but for a month, and then or maybe 6 weeks, and then you have to go for intramedullary nailing, and again you have the same problems which we started with. Is that the X-fix was on too long and the index of recurrence is too high. So I would prefer not using an X-fix. If possible, sometimes you could go for a very short period of traction. I also don't really like that. The patients don't like that. And if possible, use an intramedullary rod or use a very thin intramedullary implant, which you roll in PMMA. You can lock that temporarily until you have the soft tissue cultures.
Okay, during the preparation of the cement rod, do you have an antibiotic of choice like vancomycin, tobramycin, gentamicin, or which antibiotic do you use?
In our center, it's always the same. The epidemiology is the same. Vanco, gent is always a combination, and it's 100% sensitive. The bacteria we have in our center are 100% sensitive to that combination. So you need to look, and I remember from visiting your centers, you have a much more problem with resistant strains. This means that you have to look for the adequate antibiotics. So we published the local antibiotic paper in the GOT last year, Melandre, and they have, you see, a lot of options of different antibiotics you can use. And regarding your epidemiology locally, I would mix the antibiotics, depending on local epidemiology.
Okay, thank you so much. Dr. Mansour, please continue our case.
So this is an X-ray post debridement, and as you can see, we have an intramedullary rod with cement.
Mustafa, can I have a question, please?
Yes.
Very important one. Willem, what if by chance it turns out that your culture yielded a bacteria to which vanco and gentamicin is not sensitive? Wouldn't that spacer be just a foreign body in the middle of infection, or will it still work?
Yeah, that's actually a really good question, but that's more basic science. So what we published a few years ago was an interesting result in the AO Research Institute with Fintan Moriarty, is that we tested a local antibiotic, also in a coating, doxycycline, against a doxycycline-resistant strain. And what we found is that it still killed 70% of the bacteria due to the fact that the local concentration is extremely high. So it depends, of course, on the strain and on the MIC, but it will still have its function. The question is rather, would I go for an intramedullary implant afterwards? And then I would be a little bit hesitant with a very resistant bacteria. Then I would probably, but I'm going a little bit too quickly now, but I would rather go for an X-fix then, I think. A definitive treatment with an X-fix.
But I think, Willem, what you mentioned is a very important comment. If something is resistant in the antibiogram in the lab, this applies only if you give systemic antibiotics. Locally, yes. If you are 1,000 times higher than what is achievable, otherwise in blood, you can kill even the most resistant bacteria in most cases. So you don't need to go back and operate. I would just change the systemic antibiotics so that they are effective, but the local are probably just fine. And this combination, Professor Metzemakers mentioned, Vanco and Genta, would cover probably also in Egypt more than 90% of your bacteria.
Okay, Dr. Andre, there might be a concern that the local antibiotics would have an inhibitory effect to the osteoblasts, especially when placed intramedullary. Do we have a maximum concentration to mix with the cement?
With the cement, we know that 10% of the weight is the maximum. So if you have 40 grams of PMMA, you can go for 4 grams. Now, many times we can go even double and there will be no inhibitory effect. So we saw that even at 8 grams of antibiotics per 40 grams of PMMA, there was no inhibitory effect on osteoblasts. There only is ciprofloxacin, which we don't use usually in bone cement. Yeah.
Okay. Okay, Dr. Mansour, could you please
so
go ahead?
as was mentioned before, the antibiotic rod was placed. The culture of the deep samples that were taken turned out to be MRSA, which is a highly resistant pathogen. He continued on 1 week postoperative IV Vanco, then oral linezolid for the rest of the treatment. The WIBA counts were 7,000, ESR 40, the CRP was dropping to 6.
Okay, Dr. Willem, there was a previous evidence about a fixed 2 weeks IV before shifting to the oral antibiotics according to the culture. Do we have a newer consensus in this respect?
That's a good point. So we have the OVIVA trial, I think 2019, in the New England Journal of Medicine that shows that you can switch your oral your IV antibiotic to an oral alternative if you have it as soon as the culture results are available. This means that it can happen within 7 to 10 days. So you don't need a fixed interval of 2 weeks or 3 weeks, and in the earlier days it was 6 weeks. That's not necessary anymore.
Okay, Dr. Ibrahim, do we have a consensus about the optimal duration of the second stage? When to decide on the second stage conversion?
Actually, I don't think there's a fixed timing for the second stage. It's a mix of the general status of the patient and the inflammatory markers. As soon as you get a decline in the inflammatory markers and the general status of the patient is getting better, then we can go for the second stage. Basically, it's usually between 4 to 6 weeks. And actually, there's a trend to decrease that interval. Before it was advised to go for the second stage after a much longer time. But I don't think there's strong evidence.
What inflammatory markers, Dr. Ibrahim?
Yes, CRP and YBC.
CRP, once you drain the pus, CRP goes down. It's not conclusive, CRP.
You should have a declining trend. You should have a declining trend. And also you judge with the general status of the patient.
My question to Professor Tromplus, is ferritin, the one we are watching now in COVID, has a role to follow the infection? Serum ferritin.
Serum ferritin, it doesn't say anything else than CRP. It is an inflammatory marker, and it's important that it goes down, which means that the infection is controlled, but it doesn't say that the infection is cured. So even that we, after 2, 4, or 6 weeks, change to the definitive nail, then we should actually continue with antibiotics, and then I would go for rifampin. I know that this is not so easy in your country because you want to have it for TB, but we actually go after 2 to 4 weeks for a definitive implantation and then to biofilm active antibiotic. Oral linezolid is okay in this case, but it's only suppressive. And if cotrimoxazole would work as well, that would be a better choice and cheaper and less toxic.
Yes.
Thank you. Dr. Willem, do you consider an antibiotic-free interval before going to the second stage in order to know clinically if any regrowth of the potentially residual bacteria?
No, that's something historically done often, but we don't do that anymore. And as Professor Tromplus said, the interval is normally now 2 to 4 weeks. 3 weeks is normally the interval, and then when the soft tissues are adequate, we change. There is maybe one concern I have, and maybe Professor Tromplus can share it as well, is that in my experience that we have, and we're now also looking at that in our own series, is that the MRSA we see more recurrence with MRSA. So we are a little bit more hesitant with MRSA also with the IV treatment. And as Professor Trampo said, if you don't have cotrimoxazole and you only have oral linezolid, Andre, I would be a little bit hesitant to shift too quickly, specifically from the Vanco to the linezolid, for example. What do you think?
Yeah, linezolid after 4 weeks, patients have more and more side effects. Therefore, it's only allowed for 4 weeks, and we need longer treatment. So yeah, I think then is better longer vancomycin. Maybe implant it under vancomycin and then switch to cotrimoxazole, if possible, with rifampin. That would be probably the best treatment.
Okay.
The very resistant types, you need to be a little bit careful.
Okay, in this respect, I've observed a number of patients on Averzolid, on linezolid for about 4 or 6 weeks. We've observed like neurotoxicity and pancytopenia. So, do you strongly recommend that the maximum period of linezolid orally to be just 4 weeks?
I have used linezolid only 3 times in my life. It was always something better than linezolid. Typically, it's, for example, cotrimoxazole. It may be that you have different MRSA strains, but maybe that would be important to look, because linezolid we use only for vancomycin-resistant enterococci, but even then we have better antibiotics. So it's probably one of the antibiotics which, if we would like to register it now, it would not pass any of the agencies because of the toxicity, as you mentioned, neurotoxicity and pancytopenia.
Okay,
in our center, Dr. Baraka, in our center, the linezolid is actually a maximum of two weeks. So a maximum of 4 is really where we most often never do that, and it's in our centers we try to keep it the maximum to 2 weeks, because the problems start already after 2 weeks, and 4 weeks they almost always have bone marrow depression, and so I would really try and not give it too long.
That's a really good message to deliver. Thank you so much.
The newer one is tedizolid. It has no toxicity, but is very expensive. Therefore, I have never used it until now.
Okay, thank you so much. Those are really nice messages to deliver to our participants.
Andrew, please a question, please. Which, the Vanco is better, bactericide or the teicoplanin?
Both are bactericidal, more or less the same.
Yes.
Okay, Dr. Mansour, please go ahead with the case.
6 weeks later, the second stage was done and the cement rod was removed and converted to an intermediate retrograde nail to fix the fracture.
Okay, let's go back one slide. Dr. Willem, do you consider routine sampling during the second stage?
It's a bit controversial. If the patient is under vancomycin at that time, we would probably, in an MRSA case, do it, but it's not standard of care. No, Andre, maybe you can comment on that. But if the interval is 3 weeks and the patient is under vancomycin, and you had adequate cultures during the first surgery, I wouldn't consider it standard of care.
We do actually the culture in case that we missed something, a mixed infection, and the gram negatives are now not treated. So if there is something gram negative, we would find it.
Yeah, good point.
What we send routinely is if you remove a nail or a screw, we send it for sonication. That is the minimum.
Yeah, but you wouldn't send the spacer, Andre, wouldn't you?
Correct.
We don't send the spacers.
Not the spacers, because there is an antibiotic inside, and this will make your sonication cultures negative. Very good point.
Okay, thank you, Dr. Zohar. In this case, the surgeon have changed the fixation device from an antegrade to a retrograde nail. Do you think it's safe to open another compartment? Any risk of contamination of the knee?
Yeah, it's too risky to do that unless you're 100% sure that you have eradicated infection, and I think that you will never be 100% sure of doing that. So still you have a risk to open the knee and put a retrograde nail. Yes, of course we know that it's in that fracture a retrograde nail is much better for stability because of the flare up of at the end of the femur. But I think it is a little bit risky.
So generally, you would advise to use the same fixation methods as the primary one.
Yeah. To be on the safe side, maybe. Yeah.
Okay, thank you, Dr. Mansour. Please go ahead.
If I may, Dr. Baraka, maybe
yes,
sure.
Yes,
short point here.
Please, I'm waiting for your comments.
Is that if you look at this case, I can imagine that a colleague would say it's a bit risky. So what I suggest is that you start removing the nail, start removing all the locking screws, clean out antigrade, clean out, correctly syringe it, take the cultures, and when it's clean, then I would also suggest to go retrograde, because the problem with antigrade is you wouldn't get any stability. So the question is a little bit, do you do that immediately or not? You could also wait to the second stage maybe, but that would give you problems with stability. And I agree that stability is key here. So starting just antigrade, cleaning it out antigrade, and then go retrograde just would lower the problems that you would maybe create in the need to approximately 0, I think.
Okay, thank you so much. Thank you so much, Dr. Willem. Dr. Mansour, please.
Can we add? We do it an antigrade nail and add a small DCP as composite plate over the fracture side, so that we get more stability. Or that will be risky.
Good point. Of course, an option, but it's an open fracture. You would go through the soft tissue again, maybe give problems to the vascularity local to the bone. I personally wouldn't do it in this case.
Okay, Dr. Mansour, please continue with the case.
2 months later, as you can see, the wound starts closed very well with no discharge. The total leukocytic count dropped down to normal. The ESR is dropping, and CRP dropped to negative after 2 months. As you can see in the X-ray, the bone starts to consolidate, and the patient was also on antibiotics of linezolid for 2 months.
Okay, Dr. Willem, how often do you follow up your blood tests, the CBC, the ESR, and the CRP? Is it once or twice weekly?
Depending on the antibiotics, depending on the local soft tissue status and the patient, it's not standard of care, and we don't really follow it. So when the patient goes home and the CRP is normal and he has a standard antibiotic like clindamycin, it's not standard of care. The difference is when the patient is on the linezolid, for example, then I would 2 weekly at least, and maybe even weekly, specifically when you have to give it longer, would check. But it's not for the CRP. It's more for blood marrow depression and toxicity levels. So we don't check standard CRP and white blood cell counts.
Okay, thank you. Regarding the duration of the antibiotic treatment, the oral antibiotic after the results of the culture, there was a previous recommendation about till normalization of the ESR. Others recommend a fixed 6 weeks. Others recommend a fixed two months. Do we have newer recommendations according to the FRI consensus?
Yeah, so when the implant is removed, Andre will comment on that, but when the implant is removed, it's 4 to 6 weeks. When the implant is in place from time to first debridement, it's 12 weeks.
Okay, which means it's 3 months from the last debridement. Okay,
yes,
thank you.
Specifically in the MRSA cases here, I would, Andre, you can comment, but 12 weeks in the standard then.
Okay, thank you. Dr. Mansour, please go ahead.
These are his X-rays after 6 months. As we all can see, the fracture has consolidated. The patient has no symptoms, no wound discharge, and the patient is doing well. 1 year later, X-rays show perfect consolidation, no symptoms or wound discharge, with very good functional outcome of his knee.
Okay, Dr. Willem, would you consider routine removal of this nail in a previously infected case?
Yeah, so that's maybe a little bit controversial, but a very good question. We come back to our antibiotics. So as Professor Trumpo stated, in this case, we don't have given the antibiotics that are active against the biofilm. So there's no rifampin given, meaning that following the guidelines, you only gave suppressive antibiotics till the fracture healed. And following the consensus, this means that the implant should be removed. So in an MRSA case, when these antibiotics were given and it's a young, healthy patient, I would remove the implant, yes.
Okay, thank you for your valuable comments. Now, that's the end of the second case. We now have the pleasure to listen to the summary of the evidence by Dr. Andrei Trampus. Would you please share your slides?
Thank you very much. I will make a short summary because we said so many important things, and I must say I really enjoyed this discussion. It was one of the best webinars because you are asking so practical questions which we are daily dealing with. So I hope you can see my presentation now.
Yes.
Yes.
Yes, it's clear.
So in the first few minutes, I would like just to mention that fracture fixation device infections are one of the most common. Every 20th to every 10th gets an infection. And of course, the more open and contaminated the wounds are, the more the soft tissue are damaged, the higher are the percentages, reaching up to 70%. And therefore, we are so scared to implant something until we are sure that the infection is under control. We mentioned also today different pathogens, and MRSA was in the second case. We see that also gram-negative are quite common, and what I want to mention, in 10 to 30% infections are polymicrobial. We may find only one bacteria, but the second and the third is overgrown, and therefore we usually treat more broad than just what we found in the microbiology to cover, including also the biofilm. The biofilm is immediately present within hours, but it is up to 3 to 4 weeks so young that we don't need to replace or remove the implant, but we keep it inside and treat with biofilm active antibiotics. In fracture-related infection, this time can be prolonged to 6 weeks, some even to 10 weeks, but all depends on the soft tissue, because this will finally influence the outcome in a positive way. But as a general rule, as mentioned, in the acute infections, we retain the implant. In chronic infections, we replace it, and then we see if it's in 1 or 2 stages, and if with internal or external fixation. We mentioned already this nice article from Professor Metzemakers. This was the international expert group, and regarding the treatment concepts, which will be in the second few minutes, we actually rely, of course, on antibiotics, but 80% or maybe 90% is the debridement. We need to reduce the number of bacteria, because only then antibiotics will achieve the cure. And the reason is the famous sentence, the solution to pollution is dilution, is that antibiotics can only work if we reduce the number of bacteria by sufficient debridement and possibly local antibiotics in resorbable carrier, that then we can eradicate down to the last bacteria. If we have no biofilm active antibiotics, then we can suppress, but then we need to remove the implant before relapse will occur. And this nice algorithm, which summarizes the most important part, was shown already by Willem Metzemakers. So I will just come now to the antibiotic part. And the question was how long we treat, and you see that the total duration, including IV here in red, and oral antibiotics, here in blue, is something between 6 and 12 weeks, depending on the surgical procedure. And if we suppress until removal of the implant, then we don't need biofilm active antibiotics, and therefore here is the green arrow. One of the important questions in the first case was the empiric antibiotics, and here you can see that we prefer in open fractures something which covers broad. If you have a lot of MRSA, you can add vancomycin, and if you have a lot of resistant gram-negative, you can switch to the last resort, which is the meropenem or imipenem, and here you can see the doses. After 1 to 2 weeks of IV, we can switch to oral as soon as the wound is dry, and we have good antibiotics which can be used orally, and they are summarized in the pocket guide, which you can download for free from this website. And I think you can also get these slides. You can distribute it to all participants to this of this webinar. I also want to mention that on the 5th of May, there starts an online seminar organized by ProImplant Foundation. And for all attendees of this webinar today, it's for free if you register with this code. So just to remember this OPS free FRI. And if you put this inside, then you can attend all the 4 modules for free. And you can see here that there will be many good speakers plus some invited speakers as well. Thank you very much.
Thank you so much, Dr. Andre, for your invitations and for your valuable presentation. We've got only a few questions. Dr. Willem, do we have an evidence to support the use of the silver-coated nails?
So in trauma, there are not a lot of studies, or actually almost no studies on silver-coated implants. Most of them come from the megaprosthesis German studies that show they have a good result, specifically in their revision cases, showing a lower risk of infection. But in trauma, there's not a lot of data. The only coated implant that is available is the ETN Protect coating that has gentamicin, but it's not on the market for treatment. It's more for prevention in open fracture cases, or in cases where the infection has been treated to lower the risk of a reinfection, because the coating, although the company says it's there for approximately 2 weeks, the release of the coating is only a few days. Is it gone? The antibiotic is gone after a few days.
Okay, thank you so much. We have one final question for Dr. Andre about the use of rifampicin in cases where we have no growth and we cannot use an antibiotic against the biofilm. We all know that rifampicin is one of the biofilm active antibiotics. So what's your recommendations for its use?
I would not use it in culture negative, but only if you find a staphylococcus, whatever staphylococcus, and it must be susceptible to rifampin, and then you need to combine it with another antibiotic. Same as in TB, you cannot use it alone. If you have a lot of culture negative infections, then I would first see how you can improve the culture sensitivity, and then really specifically use, because if you use it wrongly, then you will create resistance and make it even worse.
Okay, thank you so much, Dr. Andre. Now we've come to the end of our second session. I would like to thank all our distinguished panel speakers, our dear guests, Dr. Metzmakers and Dr. Trampus. It was a real pleasure being with you all today. Thank you so much for sharing your experience and your presentation.
Thank you, Baraka, for your moderation, for your distinguished moderation for this webinar. I'm very thankful for you. I'm very thankful also for our guests, Dr. William Metzmakers from the trauma consultant of Belgium, and Dr. Andrew Trampus, infection disease consultant, Charité University Hospital, Berlin, Germany. I'm very glad that you have you with us, and I'm very proud to have you in our webinar. Thanks a lot from my heart. Again, thanks to the rest of our panel, Professor Dr. Zahir Hassan, Dr. Ibrahim Ganzouri, Dr. Mahran, Thanks to our distinguished speakers, Professor Gebeli and Dr. Ahmed Mansour, our consultant. Thanks to the participants اللي استحملونا up to 12. Thank you so much. I hope we covered all the points in such webinar. And I think there will be a continuation. Our last webinar before Ramadan. كل سنة وانتم طيبين. We'll continue this subject about the chronic and the gap solving infection. It will be the coming Friday. Thank you very much. Thanks our moderator, thanks our guests, thanks our panel. Good night and thank you very much. See you in Ain Shams orthopedic webinars. Thank you very much.
Thank you.
Thank you, Dr. Amr.
Thank
you.
you.
Good night.
Thank you very much.
Bye.
Thank you.
Bye-bye.
Thank you, Andrew.
Goodbye.
Thanks a lot. Thanks
Bye-bye.
a lot. Thanks.
Goodbye.
Steve.
A pleasure.
Bye
You're
bye.
most welcome. Thanks you. Bye bye.